All right, so let's define some things so that it makes it a little bit easier for everybody to understand kind of when we move forward here. So, when we talk about an acute injury, I know that depending on the textbook that you look at, the sources that you look at, there's some varying degrees about what's an acute injury, what's a subacute, what's a chronic injury. But for the purpose of this lecture, an acute stage injury is an injury that lasts 4 to 6 days. And so during that time, generally what's going to happen is there's an inflammatory response. And we'll get into a little bit of the histology probably on Wednesday, just as we review this for upcoming lectures. But generally what happens in acute injuries is there's swelling, pain, redness, there's going to be some heat because there's an inflammatory process that's going on, generally pain at rest, and loss of range of motion. Range of motion in this phase can be painful for the patient because there's going to be some just natural involuntary guarding of the joint. And so remember that when we talked about an acute injury, what range of motion is the most appropriate, what exercises are the most appropriate for these individuals, and what generally our goal is in this phase. So passive range of motion is going to be the most appropriate in this phase for a person who has an acute injury because, again, we're trying to decrease pain, decrease swelling, but maintain mobility of a joint. Now, as we progress throughout this class in the next several weeks, we're going to talk about specific injuries and when they're in the acute phase, what you can and cannot do. And that's going to vary significantly depending on the surgery or the injury or other factors that we'll define at that time, just because of the fact that, just because somebody's in the acute stage doesn't mean that you have to hold off everything. And I'll explain more of that in the weeks to come. A subacute phase can last anywhere from 10 to 17 days or 14 to 21 days after an injury. This is more when healing and proliferation happens, meaning that this is when all the good cells kind of come in and are trying to clean up the area, get the inflammation out, get out all the toxic stuff that's in the cells, get them out. That can last all the way up to 6 weeks. This is important because when we talk about surgical patients, for example, right, we've defined previously that it can take up to 6 weeks for tissue to heal. We've said that it can take up to 6 to 8 weeks for bone to heal. We've talked about how it can take 6 to 8 weeks for ligaments and tendons to heal. So it's really important to keep that in the back of your mind when you're working with somebody who's had an injury. This general phase is going to be all about healing and repair. So this is generally when you see inflammation start to subside, range of motion will be painful, but only when you encounter resistance at the end of their available range. There's going to be some muscle weakness. And for those who've had surgical protocols in which a tendon's been repaired, this is when you can start looking at manual muscle tests. So for example, when we get to upper extremities, we're going to talk about rotator cuff repairs. And during a rotator cuff repair, a physical therapist during an initial evaluation will not assess range of motion, or not range of motion, but will not assess active range of motion and will not assess manual muscle testing at that time because it's not appropriate. You have to wait until week 6 when all that stuff is healed to test out and see where their muscles are. And so just keep that in mind that if you see on initial evaluation, you see a patient who's had a surgery in which a tendon's been repaired, and you see that there's been no active range of motion and no manual muscle assessed by the therapist, that's a good opportunity for you to either assess it and get that information back to the patient or the therapist when it's appropriate, or have the therapist do a reevaluation of the patient at 6 weeks to gather that information and then direct you on what to do in the plan of care. The chronic stage, it's kind of that final stage of tissue healing. There's no signs of inflammation, although there may be contractures or adhesions in this phase, depending on how the patient was managed previously. That can last anywhere from 6 months to a year, depending on the tissue and the damage that occurred. And so you'll hear a lot of surgeons refer to their patients after a surgery, especially a major surgery like a hip replacement or a total knee replacement or a massive rotator cuff tear, that they're not going to be 100% or back to their previous level of function until a year after the surgery. And that's because, with all those kind of surgical procedures, especially joint replacements or massive rotator cuff tears, there's a lot of work that's being done by the surgeon. a lot of tissue damage that has to be repaired, a lot of tissue damage that's being caused. And so, you know, to be 100%, it can take up to a year for the patient to feel that way. Maturation and remodeling is the key to this chronic stage. And so collagen tissue continues to strengthen, continues to remodel according to the stresses that we put on it, or the patient puts on it. You can still see weakness and poor endurance during this phase, poor neuromuscular control, which for you guys generally means like proprioception, kinesthetic awareness. Not so much the stereognosis, like that's not a big issue when we're talking about orthopedic conditions, but you can still have patients that have issues with like motor control or balance or other things like that during all the way up to 6 months to a year after an injury. Pain is only felt in this stage generally if you really push them past end range and structures that are tight. So generally speaking, their range of motion throughout the day isn't the problem. It's when they get into those extreme end ranges and they're having to push themselves past their physiological limits that they'll get pain. Here's kind of a good showing of pain with range of motion in different phases of inflammation. So this goes back to that three-tiered system, right? Acute, subacute, and chronic. And so generally speaking, patients are in the acute phase are going to have pain in the beginning of their range, right? Because an acute injury, pain and inflammation is the big thing that we're dealing with. Pain is supposed to limit motion for a patient. And so pain at beginning ranges for an acute pain patient isn't that uncommon. This is why passive range of motion is generally most appropriate here. In the early subacute patient, they're going to have pain kind of at the extremes of motion. And so, it's not uncommon to do active assisted range of motion with subacute patients. And then your chronic and late phase patients generally have pain at extreme end ranges. So active range of motion is generally most appropriate for these. And there are going to be some varying timetables and varying ways that we're going to introduce active, passive, active assisted range of motion with our patient population. We'll get into that case-by-case basis in the next several weeks. So this brings up the question that most people have during this time. Well, what about people who have chronic inflammation or who have chronic pain syndromes? What do we do with those people? And so remember, chronic inflammation is basically the result of inflammation that hasn't been dealt with correctly. And so prolonged inflammation occurs in tissue that is continually stressed beyond its ability to repair. So, think about it, the patient who was mismanaged inappropriately in the beginning of their rehab. And so that tissue was never given time to heal, it was never given time to repair. So the body is just going to naturally start up its own chronic inflammation process in an effort to try to get that tissue to heal. Symptoms generally include, with chronic inflammation, increased stiffness after rest, loss of range of motion 24 hours after it was gained. So, people who are in this chronic inflammatory state, generally they're going to come into the clinic, we're going to stretch them out, everything feels great, and they're going to lose it. They're going to go home, they're going to feel stiff and sore. They're going to come back in the clinic 2 days later, you're going to range them some more, and this is back and forth, back and forth, back and forth. And so, you're concentrating here in this phase on working on trying to get some of that waste product that's kind of hanging out for too long in the joint or in that injured area out. So think about all the thermal agents that you could utilize for this, the ones that are going to be more deep versus superficial, the ones that are going to help kind of stimulate blood flow or increase blood flow to that area. Those things are kind of more beneficial for patients in this phase than anything else. Chronic pain syndrome, this is really an area where we can get into and start talking about central sensitization and basically changes that happen to the brain that causes these individuals to have that persistent pain for a long period of time. But chronic pain syndrome is pain that persists longer than 6 months and can't be linked to any source of inflammation or irritation. So, remember Dr. Evans has probably taught you guys a little bit about the homunculus, the primary sensory cortex of the brain, and how we have different areas of our brain that correspond to like our fingertips, our hands, our lips, and our nose, and all that stuff. If you haven't heard about it from Dr. Evans, you have to go way back probably to AMP2 or even AMP1, depending on where you went to school. But basically what ends up happening is with these chronic pain people, they have chemical changes that are in their brain, and so their brain responds differently to a given stimulus, and as a result of that, they're more sensitized to pain, to inflammation, to other things. So the way that I generally describe it to my patients who fit into this category is normal people have this kind of large window in which they can adjust to a given stimulus throughout the day, whether that's noises or light or touch or temperature or any of those things. You, on the other hand, have a very small window in order to adjust to those things. So if you're overstimulated throughout the day, or if you overwork or if you overexcite yourself, then essentially what ends up happening is you have pain. Your body responds to that by thinking it's pain. And so a lot of the stuff that you do with chronic pain syndrome patients is you work on desensitizing them, because their brain is sensitized any stimulus to be painful. So let's talk for a few minutes here after a break about management of different types of stages, acute, subacute, and chronic.